Hi, my name is Nir Uriel. I'm the Director of Heart Failure, Heart Transplant, and Mechanical Circulatory Support at NewYork-Presbyterian, Columbia University, and Weill Cornell Medicine. So the INTEGRA-D trial is actually taking two devices that we use in heart failure and combines them into one and check whether this device is safe and efficacious. So let me explain a little bit more. In heart failure patients, there is a higher risk to develop sudden death. As a result of it, multiple studies show that implementation of implantable cardio defibrillator will be able to reduce the mortality associated with sudden death. And it's indicated in any patient with reduced ejection fraction below 35% to receive an ICD, or in patient with NIA class 1 if the ejection fraction is below 30%. On the other hand, there is a device called cardiac contractility modulator. This device is a device that gives us a different solution for heart failure. It's a given non-excitatory electrical signals in the RV septum that actually able to improve the circadian regulation and improve the contractility of the heart. In several studies, there was a positive result in improving the quality of life and the exercise performance in patients implanted with the CCM. The CCM is indicated to heart failure patients with ejection fraction between 25 to 45% that are New York Heart Association class 3, and they are symptomatic despite the guideline-directed medical therapy. But those are two devices. People doesn't want to be implanted with two separate devices. So the INTEGRA-D device is the CCM-D, is a dual function rechargeable device that is powered by two battery systems. One part of the device is the CCM. The other part of the device is the ICD. So in the INTEGRA-D study, what the main aim of the study is that you check this CCM-D device efficacy in converting induced VF at an implant of 100 consecutive heart failure patients. There is a safety assessment that we want to see after 1 month for procedural complication, any kind of intervention or medical procedure that we need to do for those patients. And of course, we want to see that also the CCM is working, so we will assess the New York Heart Association classification of those patients. Bottom line, we have a new device that's composed of two other devices that previously was FDA approved. So the INTEGRA-D study is a single arm study, meaning all the patient implanted in the INTEGRA-D study is going to get the device. There is no randomization here. Patient indicated to de novo ICD without a CRT are a candidate for this study, but this time the ejection fraction that we choose as a cutoff is 40%. As you can understand, it's a little bit above the ejection fraction that is a cutoff for ICD, and the reason is that this is also a device that have the CCM embedded inside of it, so the indication for CCM is ejection fraction below 45, so we could have gone a little bit higher. There is very similar to the ICD cutoff, there is no lower ejection fraction that could not go into the study. So again, patient indicative with ICD implantation with ejection fraction below 40% are enrolled into the INTEGRA-D study. In this study, that is a single arm study, we have two phases. Phase number 1 is enrolling something like 100 patient to 127 patient. The primary efficacy objective is to see whether or not the device is providing what it's supposed to provide, and is protecting from VTVF, and we are going to do it by producing VTVF. After the first 100 patients, we will continue to enroll up to 300 patients, but those patients will not need to have the defibrillator threshold testing, meaning we are just going to continue to follow those patients to make sure that those are given appropriate shock if necessary, and to check the 6 months New York Heart Association classification of all those 300 patients. So first of all, we enrolled the first 100 patient, and the main result that we presented in the last HFSA in the late clinical session is of the first 100 patient that received defibrillating testing. The mean age of the patient was 62, 28% of them were female, and very similar to all the heart failure study, the majority have diabetes, 45%, hypertension, 81%, and chronic kidney disease in 25% of the patient. The patient was pretty sick. Their ejection fraction in average was 30%. Ischemic cardiomyopathy is 52.5%, and 45.5% of the patient was near class 2, and another 47.5% of the patient were near class 3 patient. Side by side with that, it's important to emphasize that in our study, the patients were on most recent guideline-directed medical therapy. 54% of the patients were at least triple therapy, and 35% of the patients were on quadruple therapy. And this is a big change compared to all the other device study that we're talking today. And side by side with that, we're talking that SGLT2, that is the new medication that came into the guidelines, was given in 53% of the patient. So first, let's talk about the main aim of the study was actually to successfully implant the device. So we implanted the device successfully in all those 100 patients. And we tried to induce sustainable shock, and we successfully did it in 100 patients. And the device successfully converted those shock in this patient in actually all those patients. So we had a 100% success in converting our patient to shock. So that's the main thing that we want to emphasize. The defibrillator in the CCM&D work as it's need to be worked with 100% success rate in our cohorts. Our complication at 30 days were pretty minimal. There is only one patient that had lead dislodgement that required revision. There was one patient that had infection in the pocket that require only antibiotic therapy. And there was one patient that had a worsening heart failure syndrome. Two patients had other adverse event was hypertension, the other was chest pain due to pericarditis, but those were the main adverse event of the study. So if you want to emphasize the results, there was no inappropriate CCM during ventricular arrhythmia, no event of CCM leading to inappropriate ICD over sensing. 89% of the subject receiving the recommended therapy with CCM dose at 30 days, meaning also get the CCM therapy on top of the defibrillator. And 91% of the subjects had 100% compliant with charging the device that need to be charged regularly. This is important because this is on top of 100% success rate that I said earlier in successfully terminated the shock in the DE's testing. Now let's go to the 6 months results. In the 6 months results, we want to see whether or not only that we provide protection with the ICD, rather that we provide a better therapy for the heart failure with the CCM. So in the 6 months result, 88% of the patient improve or remain stable with their New York Heart Association. If we actually dive deeper into it, class 3 patients showed the largest improvement and class 2 patient had a modest improvement in that regard. And we had 11 patients that had worsened. 6 patients had a frequent charging of non-compliance, frequent charging non-compliant event, meaning that they didn't charge their machine, so we not anticipating to see an improvement. And we have one patient that they have a ischemic event. Again, 88% of the patient had stable New York Heart Association classification or improvement in their New York Heart Association classification. One thing that is very important, if we take the patient, the proportion of patient in near class 3 or 4 patient that improve within 6 months, we found that 55% of the patient improved. This is very similar to what was seen in the CRT study, in the Champion study, for example, that was a companion study that was 57%. However, there's a big difference here. As I mentioned before, in our study, the majority of the patients received modern guideline-directed medical therapy that include for medication. So if I conclude everything, we 100% of the patient undergoing DE testing successfully defibrillate them properly, successfully perform ICD function and deliver appropriate CCM therapy. No inappropriate CCM ICD interaction occur despite the hybrid creation that we have here. The RV septal lead position demonstrates reliable defibrillation efficacy. No unexpected device complication at 1 month, and the preliminary 6 months show that contrast symptom improved, remain stable in 88% of the patient. Bottom line, CCM-D provide an integrated therapy for heart failure with reduced ejection fraction, offering both symptom relief and sudden cardiac death prevention, and that's what we want to achieve. So first of all, we need to wait for the 300 patient that we will actually already finish enrolling, and hopefully we'll be able to present the data in coming meeting around March, April, May in 2026. If those data will continue to look as it is, I don't see a reason why a patient that have a need for a defibrillator will receive only a defibrillator and not a defibrillator with a CCM if you have half a reduced ejection fraction. Meaning, as a clinician, I can tell you that every time I explain a patient about the need for an ICD, he asks me, where am I going to feel better because of it? And I told him, no, this is like a warranty. The defibrillator will help you if you will have an arrhythmic event. The CCM-D is going to prevent arrhythmic event for causing sudden death. However, it's also going to improve the symptom as seen in the first code of this study. I'm very excited that instead of just giving a patient a warranty, we're going to give him also improvement in quality of life. So I do believe a lot of patients that require ICD, instead of getting ICD alone, they will receive the CCM-D, so it will also be able to take care of their heart failure symptoms.